Yeah, please send us your views and questions if you have them, because we're asking tonight, is the proposed national health insurance workable and sustainable, and will it really make South Africans healthier? Last week, the Minister of Health, Dr. Zweli Mkhize, published the NHI bill. It starts to outline a system that will allow everyone in South Africa, the rich and the poor, access to quality health care. Those who can pay will contribute to an NHI fund. Their contributions will cover those who cannot pay. Now, obviously, a system that protects the health of citizens is laudable. It could even help economic growth in this country. But the bill has received heavy criticism from opposition parties, the private healthcare sector and investors. The uncertainty around private healthcare, around medical aids, leading to a sell-off of some stocks. And there are warnings that young doctors, the very ones needed for a long-term system, could leave en masse. Well, President Cyril Ramaphosa has backed the bill since then, saying the NHI, whether people like it or not, it's going nowhere. We're joined tonight by Dr. Olive Shisana, who is a special advisor to Ramaphosa from the Department of Health, head of the NHI War Room in the Presidency. We're also joined by Sasha Stevenson, the head of the Health Rights Program at Section 27. From our Cape Town studio, Dr. Chris Archer, who is the CEO of the SA Private Practitioners Forum, representing doctors, and Dr. Paula Armstrong, who is a health economist with FTI Consulting. Good evening to you all. And Dr. Shisana, if you don't mind, the rest of you, please listen in. I'd like to start with you because I think people have so many basic questions about how this is going to work, and it's leading to a lot of analysis, maybe some criticism that we can put down. Let's start with the private providers. As I understand it, won't be able to necessarily duplicate what state providers will offer. So my question to you is, say you are going to a GP. Does it have to be a state GP? Say we'd love a system that works well, but say there are queues. Does that mean those who could afford private healthcare and those who can't will be in the same hospital in the same queue?
I'm glad you're asking these questions because there's a lot of misinformation out there.
Indeed.
Actually, an organized misinformation. Here's the fact. Here are the facts. First of all, NHI is part and parcel of a global initiative, which is started by Sustainable Development through the United Nations. All countries that have signed up to it, and there are many, hundreds of countries that have signed up to the National Health Insurance or Universal Health Coverage, say we are going to make health care accessible to all, and it has to be quality health services.
Yeah.
NHI is not a medical scheme. Let's be clear on that. It's not a medical scheme. It's a health financing system that actually protects all the people in South Africa, which means that the way it's going to work, you start with the NHI fund, which is set up, and that NHI fund is going to use the public and private sector facilities. Private sector and public sector, providers. So this issue of the fact that the private sector is not going to be involved, I'm not so sure where it comes from.
Yeah.
Because it's clear in the bill that there is a change in the way in which services are provided. There is what they call a provider and a purchaser split. The fund becomes a purchaser. It pulls all the resources that it has. It makes sure that people can use both the public and private sector as long as they are accredited.
Yes.
Now, what does it mean to be accredited? It means that they must have been approved by the Office of Health Standards Compliance. In other words, certify them to say you are capable to do what you're supposed to do, to provide health services that are good. Number two, it has to be approved and accredited by the National Health Insurance Fund according to clinical standards that are good. For the first time in this country, we're actually equalizing the regulation of the public and the private sector. Normally we regulate the private sector, but we don't regulate the public sector. This time around, the government is saying, no, we're going to regulate all of them in such a way that the quality should be the same in both sides, and it should be good quality. We're using international standards to determine whether the services themselves are good or not good. So you can see from the information that I've provided, it will be a better system. No longer will you be injured on the street and the ambulance comes in and they say, well, do you have medical aid? If you don't have medical aid, no, they jump, they go somewhere else, and then they'll wait for the state ambulance to come and pick you up. They'll be able to pick you up and take you to all those accredited facilities, whether public or private. So that's a big change that is going to happen.
Okay. And I think everybody agrees that South Africa needs quality health care for all. I'm still trying to get to the nitty-gritty. Okay, so say this system is quite busy, you need a GP. Are rich and poor going to be in the same lines to see GPs? Or can I say, I still want to pay a bit extra because I need to get to work quickly and I'm going to pick a GP that I know won't keep me waiting? Simple question.
A simple question is this. In a country that has not been transformed, with a history of apartheid, we shouldn't really be talking more about the question of if you have money, you must have a different service. If you don't have money, you mustn't have a different service.
The reason I raise this, Doctor, the reason I raise it is because economists are talking about the value of time. So they're saying if we have the same problems in this system as we do in the public healthcare system now, what you're saying to people is they have no choice. They may have to wait. And economists are talking about the value of time to people who are very busy.
I think the problem is that people are looking at the future with the eyes of the present. If you say that you are going to change the system such that you are accredited, if you are accredited, what does it mean? It means that you must have enough professionals to be able to deliver the service. It means that that facility must have all the equipment that it needs to deliver the services. It means that you must introduce telemedicine to be able to decongest the health facilities. Some may call it mHealth. So it means that in the future, the health system will not be the same. That is why there is a requirement of accreditation. Accreditation itself means that you are fundamentally changing the quality of the services that you are providing. It's not really that you are going to go to the same healthcare system that you see now. Because the problems we have now are not rocket science. Let's agree.
But why are we not fixing the problems we have right now? Because let's be honest, we have a system, a public healthcare system, that should provide services to whoever needs it. Technically, if this system was fabulous, nobody would need medical aid. We would use the system. And some of the criticism is that the bill does not adequately address the problems in the public healthcare system now. It's a complete overhaul, but it's not addressing those basic issues.
Unfortunately, in the bill, you cannot address the nitty-gritty parts of the system. When we say you accredit, what does accreditation based on quality standards mean? It actually means that before you can be contracted to become part of NHI, you must meet the quality standards. That is articulated clearly in the bill. Secondly, we have to accept the fact that the way that the bill is structured such that the NHI will be rolled out as you improve. In other words, you take a facility, you improve it, you make sure it has everything, you put in a sign, NHI ready, and then you start using it as an NHI facility. So we're not going to take facilities that don't work and simply say, no, from now onward, you're just going to deliver NHI services. No. You cannot be contracted to deliver NHI services, both public and private, unless you meet those requirements. Even in the private sector, there are many GPs that won't even meet those criteria until they actually improve it. That is why the Office of Health Standards Compliance is developing standards that would assist the GPs to be able to improve their facilities. They'll be giving more services, better facilities than they are doing. Right now, if you go to the private sector and you say you have TB, what happens? They send it to the public sector because they don't bother to treat TB. Now, there are many of those kind of services that private sector is not going to be able to deliver. Therefore, they have to get themselves ready to deliver all the services. The public sector right now has got a comprehensive service that they are providing. And we need to make sure that that comprehensive service is improved. With additional resources, what we're going to be able to do is we're going to be able to attract those doctors that are in the private sector, the allied health workers that are in the private sector. So we'll be able to share between the public and the private sector in order to be able to deliver good quality services.
Okay, so thank you, and I think we'll get to some more of the basic questions as we go along. Okay. Sasha Stevenson from Section 27, so you guys are all about protecting the poor. Are you behind this and the way it's been put in the bill and explained?
So I think the first thing to say is that there's absolutely no doubt that we need to fix the problems in the health system. And when I say health system, I don't just mean public health system. We have a terribly inequitable system. Funding is inequitable, quality of service is inequitable, regulation is inequitable, and it doesn't make sense that we have this system, that we've set up the system the way that we have. And so it's very clear that something needs to change. National health insurance is South Africa's answer to universal health coverage, which is this principle that Dr. Shisana spoke about, which is the idea that people should be able to access services on the basis of need and not ability to pay. And of course, that's absolutely what we need to do. And of course, we can't provide for all the detail in the bill. We can't deal with all of the difficult issues. There are some things that need to be dealt with in the bill. There are some details that need to be hashed out. And the reason for that is that we need to ensure that we're setting ourselves up to go in the right direction. So the principles of NHI, that there should be universal health coverage, that everyone should access the same health services, not based on how wealthy you are, but based on what you need, are absolutely right. Some of the details are concerning. And
tell me one or two that you are concerned about.
So I think that the primary concern really is in relation to accountability and the NHI fund. So that the fund is set up at the moment as a structure that will hold all of the health budgeting in the country. It'll have the public health budgeting, and eventually with introduction of new taxes, etc., it'll hold some of the money that's currently used for private healthcare. So this is a large pool of money, and it's governed by a CEO, or it's managed by a CEO, and it's governed by a board. The board at the moment, according to the bill, is accountable to the Minister of Health. It's appointed by the Minister of Health. The ad hoc committee that assesses applications are appointed by the Minister of Health. And this kind of centralization is a problem, not because there's anything wrong with the Minister of Health, but because we have to set up systems to ensure that any kind of entity is protected from the possibility of mismanagement. Okay. We need to set up those systems and not hope that those systems will evolve. And there are things that you can do to render these kinds of structures better managed, more transparent, and more likely to hold accountable the people running this big sum of money.
So I'm glad you've raised this. So hold number two. Doctor, this is coming up over and over again, that this fund is going to be massive, bigger than Eskom, very centralized, a lot of power in the hands of a health minister. We don't know what the future health ministers will be like. A lot of tenders here. Could this be a huge tool for corruption, for state capture in future? That's the concern.
I'm glad you are raising this issue, and we've been proactive. There is a public health forum that has been set up by the Special Investigative Unit, the Hawks, the Financial Intelligence Services, the Department of Health, Section 27, and many other organizations. They formed a forum where they are going to be setting up systems to ensure they can detect fraud, not after it happens, but before it happens. In other words, they can detect it as it happens. They are going to develop a risk engine, and that risk engine will be operational even before money can come into it. It will be pilot tested, checked to make sure that the fund is used for what it's supposed to do. And this is going to be possible. You know why? Because NHI is rolled out facility by facility. So as you bring them in, you have an opportunity to test to see whether your systems are actually working well or not working well, and correcting them as you go. We may not have all the answers to everything that has been said. In fact, even some of the complaints that you might have may not be real when you start testing them out. Or even what you say we want to do may not actually pan out that way. That's why there is a research angle to the National Health Insurance to make sure you can pilot test as you go. Not even pilot test, but demonstrate as you go to see whether is it working, is it not working.
Is there not an inherent vulnerability of a very centralized system? It's open to all these issues.
First of all, let me say that 256 billion, which is what it will cost to implement NHI by 2025, if you run it, over that period. So the 256 billion vis-a-vis the 220 billion that the state is already spending now. So what you're talking about 30 billion or more, slightly 30 billion or more, that will be coming in from the other sources. So it's not really so much money. You know why people say it's a lot of money? It's because they add the private sector amount and the public sector amount. They say 400 billion, my God, that's a whole lot of money. It's not true. It's not a lot of money.
Okay,
it's
so for the state, only an extra 30 billion.
May I?
It's 30 billion only that is actually required. That's the work that we've done with National Treasury.
If I may interject just on a few points there, because I think that there is important anti-corruption and health work going on, particularly led by the Special Investigations Unit. And that kind of detection of fraud and corruption and dealing with it once it happens is important, and it's a very important part of this process. What that doesn't answer is the structure of the board, the way that the fund is in fact governed by the board of the fund and the appointment of various people within that fund. So it's fine that we are going to be able to assess whether fraud has happened in facility, etc., but we need to set up the systems in a way that makes it most likely that we're going to be able to prevent it. And that's not outsourced to the SIU, which is a very important function. It needs to come into the governance structure. And the second thing, if I may, is that we, while the amount of money that we're talking about may not be huge sums more than it currently funding in health, the way that health funding currently works is it flows from Treasury to national department to provincial departments to districts. It's not a centralized pool of funding. So it's quite a different situation. There's nothing inherently wrong with that, but we need to set up the systems that are required to protect the health system, and that includes protecting the funding.
Okay, so let's talk about funding, because we have a health economist with us in Cape Town, Dr. Paula Armstrong. So you're hearing this won't cost the country that much more. Very different to the alarm bells that have been going off, that South Africa could be bankrupt by this, that the middle class will receive taxes that will become unsustainable because they've already got a lot. Just give us your assessment, Doctor.
So I think what's important to remember at this stage is that the NHI fund, the NHI bill at this stage sets up the NHI fund. It sets up the payment mechanism whereby the government will procure services from the private and the public sector for beneficiaries. At this stage, the NHI bill cannot give us an indication of what the cost of the NHI will be. That depends crucially on what those services in the NHI basket will be. At this stage, we don't know what that is. So with respect, I'll disagree with Dr. Shisana to say that the NHI will cost us 256 billion. We simply don't know at this stage. She is correct in pointing out that there is a figure being touted, about 450 billion, as the ultimate cost of the NHI. That's not the ultimate cost of the NHI. What that is the pool of potential revenue from the public healthcare the public healthcare budget and what is spent via medical schemes in the private sector on healthcare. So until we have a more complete, certain list of services that will be offered by the NHI, the cost of the NHI is still unclear at this stage.
All right. Do you want to respond, Doctor?
I want to respond. What I've just heard is a question of this huge medical aid scheme that uses the resources from the public and the private sector. That is not what NHI is about. NHI is about pulling the resources largely from what we already have and then filling in the gap. And it's very easy to fill in the gap. Very, very easy. In fact, even without putting any taxes until 2025, we will be able to implement NHI. We don't actually need extra huge sums of money between now in 2025. That's why I indicated that the amount that will be required will be around 2025, not now. So we don't need to focus a lot more on the taxes. No one is going to be paying all those taxes. But the other thing I wanted to say with regard to funding, you cannot put funding in a bill. I've never seen a bill anywhere. That I worked in Washington, D.C. for many, many years. I've worked in Geneva. I've worked here in South Africa. I've never seen a bill that actually states that with NHI or universal health coverage is going to cost this much. That is put in what is called a money bill. A bill that is put by the Minister of Finance, which will probably be put in around 2024, 2025, to say that that is how much it's going to cost. So let's get away from the idea that this NHI is actually a medical scheme. It's not. And that's what's confusing people. That's why they keep saying money in the private sector is going to come in here. Yeah. There's no money in the private sector that we said we're going to take. So none of us have said that we're going to take the money that is in the private sector. We're saying individuals are going to be taxed depending on their income levels. And let me say one thing very quickly. Let us remember that whatever it is you are paying, you, the listener, the consumer, whatever it is you are paying for medical scheme premiums, it's not going to be the same as what you're going to pay for NHI. It's going to be far less. You're actually going to have more money in your pocket than if at all you continued with your medical aid scheme. We've done the calculations. The reason for that is simple. It's a national rating. In other words, risk rating. It includes everybody. That's say because you are poor, because you are sick, which is what medical aids do. We don't do that. We simply take everybody in the country. So the risk is lower, and therefore the amount that you have to pay to contribute as an extra money to fill in the gap is far less. Than what it is now.
Okay, so we've spoken about funding. Besides funding, you need doctors, and we're hearing warnings that doctors are feeling so uncertain that many young doctors may leave. Dr. Chris Archer, representing private practitioners, is that still a concern for you?
Francis, yes, it is. And I think the problem is and I'm speaking primarily from the position of a private practitioner myself. We don't have any information about how private practitioners are going to be contracted and at what rate. You know, there's a difference between a doctor employed in the state service and someone who's running his own business and providing a service. The cost implications for that individual practitioner are vastly different. Now, from what we've heard, medical schemes are going to be restricted to only provide complementary healthcare services. In other words, services that are not going to be provided by NHI. Now, no one who currently belongs to a medical scheme is simply going to continue paying to belong to a medical scheme if all they're going to get out of it is to be able to access those sort of services that are not provided by the NHI. So there will be a major collapse, in my view, of the medical aid industry. So what we are concerned about is there has been no research. You know, there was a socioeconomic impact assessment that was done. It looked at 3 different aspects. It looked at full privatization, and nobody is suggesting that is what is needed in this country. It looked at maintaining the status quo, and again, nobody agrees that what the status quo is acceptable. So everybody is in agreement that we need a form of universal health care that provides good quality health care at an affordable price for all South Africans. And our concern is that the NHI model is not the appropriate model for this country. There are many different ways in which universal health care can be provided. And the World Health Organization has been quite clear in stipulating that, or stating that each country needs to come up with its own solution. And the idea of pooling funds and creating a monopsony organization that will allow the minister to determine prices in the private sector without understanding what the costs of providing that service are is potentially very concerning. And a lot of young doctors are looking at this and saying, excuse me, are they going to be able to provide a service under these circumstances? Yeah. So and I think because of that, a lot of them are starting to consider what are their alternatives. And we cannot afford to lose more doctors or healthcare providers in general. We need to encourage them to stay, and we need certainty. It's policy uncertainty at this stage, which is a serious problem.
Okay, so let's get a response to that. And that is a question being asked. Will the health minister then decide to cap earnings and decide how much each and every doctor can earn? In which case you are saying there's no role for sort of private healthcare providers who maybe could earn more based on supply and demand.
Remember that public health and NHI, it's a public good, okay? It's a public good.
Yeah.
Being a public good, it means that you have to make sure that what you have is affordable for the country. And when I say the country, I mean the country, everybody in the country. Everybody in the country must be able to get access to healthcare. It's not going to be the payments as they are in the public sector right now.
But Doctor, my question is very
Secondly,
simple. Could the earnings of doctors be decided by the health minister, all doctors?
There is a committee that is going to work on the pricing of how much should actually be charged. And that's one area of research which would invite doctors, by the way, to participate in that research so that we can agree on how much is reasonable in terms of capitation. In other words, the number of patients that you see and this contract that you are going to have. One of the things that we've made it clear in terms of our planning is that there is going to be a research that is going to be studying the contracting models. There are various models of contracting. We haven't decided what that is going to be, because at the end of the day, we have 5 years to be able to work through some of those things. But for right now, when we start, we're going to be demonstrating through research, and we'd invite the doctors to be part of that process.
Yeah. But doctor, so you're saying yes, the state will decide how much doctors can earn. And I'm not talking about encouraging greed right now, but we're talking about young doctors who maybe want to know that they've made the right career choice, they want to plan their futures and know, at least now they know in the private healthcare, okay, that's what I'll earn. Are you saying that the state will be able to cap their earnings?
With their participation.
Okay.
With their participation, yes.
Okay.
I do not see any way that government is simply going to say that, look, this is what I'm going to do without having engaged them. We're going to engage them. This happens all over the world, by the way. When we talk about, doctors are going to go to other countries, the whole world will be discussing universal health coverage in September. I'm going there to the United Nations. We'll be hearing what other countries are saying about how they set up those capitation rates, how they do this. We'll be learning from that. So we're not really closed as a government to this. We're saying we continue to learn. Just as much as you continue to learn, just as much as you do, we all are continuing to learn to understand. And
you can't give those doctors any idea of what those earnings will be?
I cannot, because it has to be negotiated. It's almost like when you're in the bargaining chamber. When you're in the bargaining chamber, what do? Do you come in and say, no, this is what I'm going to put in, before you actually get to that table? No, you don't. You have to have all the information with you, sit around with them, and have those negotiations, test to see whether this works, this one doesn't work, and so forth.
Ms. Stevenson, you've got a comment?
Yeah, I just wanted to maybe add to what Dr. Shisana said. I think a lot of the debate around NHI has gotten so black or white. It's either wonderful or it's terrible. And I think another point for the need for change is that at the moment, doctors in the private sector know that they can make very decent livings. Yeah. But the private sector also isn't sustainable in the way that it's currently operating. And the costs of medical aid is going up, and the risks to doctors are changing. So it's not the case that at the moment doctors have absolute certainty and they're going to be able to carry on, but under NHI it's all going to be different. I think we need to recognize the nuance in this debate, and there's too much polarization, there's too much black or white. I think there's everyone recognizes the need to change. We need to see where the problems with the proposals are and try and remedy those proposals. But the current situation in public or private is not sustainable. How do we make it better? And how do we not create a system where anybody who asks questions is a problem, and we all have to go along where there are concerns with the system.
Dr. Archer, did that appease you at all, that this is going to be, yes, doctors will be in a bargaining council of sorts. There will be negotiation.
Yes, but you know, Francis, we've had 10 years in which this debate should have been taking place. We've had no debate. We are no wiser today than we were 10 years ago. We all appreciate that the current system is untenable. It's unfair to those people who don't have the resources to access the private sector, and for people who can, I am in absolute agreement with Sasha that the cost of belonging to a medical scheme is becoming unaffordable for many people who are currently literally hanging on by their eyebrows. So we have to change both the public and the private system. But my contention is that there has been no research, there has been no debate, there has been no attempt to understand from the Department of Health's point of view the position of the private sector. We wanted to participate in this debate. We've got absolutely nowhere after 10 years of trying. So what's going to change? That's my question.
And that's a good question, because Discovery Health, we saw a whole lot of stocks falling this week, and investors saying there's still so much uncertainty, and we have been talking about this for a long time.
Well, you know why there's uncertainty? The media is largely responsible for that uncertainty. And I say so because the media is the one that makes it as if NHI is going to start tomorrow, because the bill has actually gone to Parliament.
No, but let's be honest, 2026, a year has been put, and it's not far away.
Let me say this. It seems like tomorrow, Discovery is not going to have any more patients. So the investors are getting scared. They're saying, no one is going to be, subscribing to Discovery. It's not true. Discovery will continue to have its income all the way up to 2026. What the bill does, it gives all these people sufficient time to adjust to the changes that are coming. So they can continue now doing whatever it is that they are doing.
But you're saying those changes still need to be ironed out.
Yeah, but they know that those changes are going to happen in 2026. The question of how much doctors are going to be paid, obviously, is going to be discussed. I must say that it's not true that there's not been any engagement with the doctors. It's not true. There's been quite a lot of meetings that have been held with the doctors. The fact that one was not particularly in that meeting doesn't imply that there was no communication with the doctors throughout the country. We did. All the doctors that we've been working with, they've been understanding what it is that's going to happen. But the thing is, you can't finalize your negotiation on something that the law still has to approve. Once the law has been set, then you have got the right now to start discussing, because there's something that's a bit more certain.
I'm glad this has come up. You have confirmed today that the state will be able to cap doctors' salaries. We don't know at what level. But I think for private hospitals, say, I'm sure they need to plan for the future. So suddenly now they don't know if their operations are going to be profitable. An analyst said something that was interesting. He said, this seems almost vindictive of the state. Instead of running two systems together, lifting up public, it seems like an attempt to crush private healthcare. Can you respond to that? I didn't say it, but somebody raised this thing of a vindictive attempt to harm the private sector that does actually need to plan decades and decades ahead. That's why we're seeing Discovery Health shares go down.
Did people actually read the bill? Because if they read the bill, they would have known very clearly that the providers of services are going to be the public and private, meaning that it is the clinics, it is the doctors, it is the hospitals.
Yeah.
Did they actually read that? Because if they read that,
they're presuming that it will be capped, that prices will be capped.
Well, all over the world where they've introduced universal health coverage, You have to cap it. If you don't cap it anywhere in the world, if you don't cap your healthcare, you bust your budget and you end up without health services. What is worse now? Should we continue with people paying 10,000 rand a month for medical aid for a family of 3? Is that what should be? I mean, I'm asking myself a question.
Yeah.
Who are we protecting?
But
are we not protecting the people of
Doctor,
South Africa?
In response to that, somebody could say, why don't you start by fixing the public healthcare system so a family of 3 doesn't even need medical aid? They can go to public hospitals that work.
Okay.
And then suddenly there are options and people can decide. And private healthcare fits in if there's a place for it.
Can I tell you something? 76% of the whites in this country have got medical aid. 10% of the blacks have got medical aid. So when you start saying black people go and use the public sector, so you are saying 90% of the black people in this country must continue. Hold on, let me finish up.
You mentioned somebody who 3 people on medical aid.
Yes, and they are part of that. Yeah. They are part of the numbers that I'm talking about.
So you were talking about people on medical aid.
I'm saying that with 10% of the black people having medical aid, we are saying 90% of the black people must continue to use the public sector as it is, because the NHI itself is supposed to improve the quality of the health system. As I indicated earlier, and I'll repeat this, every facility that is going to become part of NHI must actually meet the quality standards. It means that we are not going to have the kind of health system that we have here. We are overhauling it to be a system that you'll be happy to go to, the system that you'll be happy to use. That's what we're creating. If the system is the same between the public and private sector, why would it matter?
Okay, so Doctor,
Why would it matter?
We have a great question from one of our viewers who says they're trying to see the vision, the future that you are talking about, and they want to know if there's a global model, but we don't have much time. Before I come to you to end, Dr. Paula Armstrong, I just want to give you a word here. Maybe you could comment on those global systems that we've seen, what works, what doesn't work. Is there a model we can look to for South Africa?
What I'd like to add at this juncture in the conversation is that internationally, when we talk about universal healthcare cover, we're talking about the system that provides healthcare cover to the uncovered part of the population. So internationally, and I'm talking about countries from Switzerland to the UK to Brazil, on the other end of the development spectrum, the private sector remains intact. And for the private sector to remain viable and intact, medical schemes must remain viable. What will happen under the current model, should the NHI provide comprehensive services, medical scheme membership will decrease, which will decrease risk pools, which will push up medical scheme premiums dramatically and will make the medical scheme industry unviable. And internationally, we haven't seen a system that limits the role of the private sector in pursuing universal health care. So universal health coverage and access to high quality coverage requires a viable private sector and focuses on the part of the population that is not covered by medical insurance.
Okay, so thank you. And I don't know, that's my understanding of health insurance in the UK. A lot of people use it, but there's still a little space for the private. What are you looking at? Which model? Let's end there.
What I'm saying is that if you look at South Africa and Namibia, they are the outliers in the whole world insofar as the proportion of the population that's paid for through medical aid.
Yeah.
We're a total outlier. We shouldn't be there. So when you come in and you say that all over the world this is what they do, evidence doesn't show that. Evidence is contrary to that. In fact, the public sector is the one that puts in more resources for people to be able to have access to good quality health care. You are never going to be able to cover all the people in the country and treat them equally on the basis of equity when you actually say that let the private sector, let the market run the way it runs. It can't be like that. This is a public good. Public health, NHI is a public good. And let's remember that.
All right, thank you all. I wish we could chat for another hour. You've answered some questions. I think there's still some concerns, still some issues we need to find out as we get closer to 2026. But I have no doubt we'll discuss again. That was Dr. Olive Shisana, who is the special advisor to the President from the Department of Health, head of the NHI War Room in the Presidency. Sasha Stevenson, head of the Health Rights Section program at Section 27 in Cape Town. Dr. Chris Archer, the CEO of the SA Private Practitioners Forum, and Dr. Paula Armstrong, a health economist with FTI Consulting. Thank you for being with us on The Full View. We take a short break. More to come.